welcome to our, what should I call it, micro course, because we have so few people on phacoemulsification. We listen to a lot of methods in which lenses can be suspended and put. I'm going to add on to it and try and show you a technique which makes life very easy. In case you ever need to suture a lens inside, this will be the method which you should really consider doing. I'm going to talk to you on 3 quick techniques by which it can be done. And after that, we'll try and see if we can get some more good speakers for you. Dr. Haldipurkar has also come. Welcome. The first talk I'm going to talk to you today is essentially on what I call as trans-iridial suturing. It is a technique which is quite different to all the methods which you will probably have seen earlier. And it involves a system which is quite different to what you have seen earlier. What we do essentially here is you go straight, do something which is not talked about or even done earlier, in which you do a scleral corneal suture directly through and then suture your implant. This is a short animation just to show you exactly how it works. What we are trying to do essentially is to suture the implant directly through the iris and through the cornea, through a little groove. The advantage of using the groove is that it buries the suture. Nothing is visible afterwards. It's very simple to do and it's quite effective. There's no gymnastics, nothing which needs to be done, and that is why the systems work so well. All you need to do is make a little dissect off in 2 little planes on both sides. It looks a little odd, but I'll follow me as I go and you'll find it interesting. At this point, you use a guarded knife. You can use anything which is available, but a guarded knife works the best. You set it down to a 0.4 axis, which is roughly the half thickness of the sclera, and make 2 vertical cuts on the side. Nothing more needs to be done. So there are 2 cuts which you have done on the sclera and nothing else. Now use your suture, which is your Prolene suture. Thread it across to the opposite side and railroad it out. All peace and quiet, no gymnastics, nothing to be done. Sutures then pulled out to the side, easily and simply. This is the time at which you will finally enter the chamber and take your suture out. Suture your loops to whatever you want to and introduce your lens inside again. This is a Rayner lens to which it is sutured, but any lens you can apply. And so you can take it and make your incisions, as I said, guarded knife, and you make your and continue. Pull your needle out from the opposite side. Take your suture, suture it onto the lens, flip your lens in, And then all you need to do, once you've sutured it and slipped it in, move it in, up to now it is just straightforward surgery. The interesting part is how we close in the end, which is what makes all the difference to the procedure, and which is essentially the difference which we'll be trying to show you. So you put your lens inside, you introduce your needle from the side. Now comes the interesting part. You remember those two little incisions we made? You take your needle and go into the depth of the incision and take it out from the other side. So in essence, what you're going to be doing is burying your suture right in the depth of the scleral incision that you have made. And you tie your knot there. Advantage is that the knot gets buried into the depth of the 40 micron incision that you have made. In the end, nothing is visible. Just a lens sitting there peacefully, a sclera cover on top, and that is the end of the whole affair. The same way here, see it again carefully, because this is the interesting part. Go in the depth of the incision and take it out. In the groove which you had made. And then tie your suture there. Tying the suture there automatically eliminates the problem of any knot, anything visible, nothing is there. It's all buried up. As a matter of fact, nobody will later on, when people see it, they won't even know what you have done. And the conjunctiva is then just apposed at the side or coapted, utilizing a coaptation device. Let me now go a little ahead. And show you a modification of a subluxated bag using a Canabrava proline fixation technique. Proline fixation has been around for quite a period of time. Note this lens. The lens, bag, everything is loose. As you notice, everything is shaking. You're not going to be able to suture this lens. You suture it to one side, the other side is going to fall off. It's not of any use, so you know that you're going to remove it and put it in. Remove a small conjunctival area at the side. A little cautery to cut down the bleeding a bit. 3 millimeters on both sides, you make a little incision. The reason why I'm doing this marking is because the needle will enter 3 millimeters away and 3 millimeters to the side. Easy to remember. Why do you do it this way? For the simple reason that it buries it. Subsequently put in an AC maintainer, always a very useful little device. So the needle goes in horizontally 3 millimeters, then vertically turn it round and insert it in. Once you've done that, you can remove that. The lens will come out, and as you notice, the bag will follow suit shortly because everything was dislocated. You know that it's going to come out. Once that is out, the next step which you do is just flip your lens inside, insert an air bubble, and use your proline loops. Close your incision. I'm an old-fashioned surgeon. If you open an incision, you close it. You don't leave it open for any period of time. And you take your little proline sutures, thread it into a needle, which you can see here. And after threading it, you move it and insert the needles. What you now do is punch a hole into the lens on both sides, and through the little hole which you punch over a rubber bung, you thread the proline in. So the proline is threaded over, and you move it on top of the lens, and you move the lens into the place. As the lens is moved into place, you can then make use a low temperature cautery to create a little stud. And this enables a little, as one would say, a stud which looks on and hooks on well. We have Dr. Shri Ganesh with us, who is the one who originally showed us this method, I think 3 years ago. And all of us since then have been following it with a little modification here and then. Finally, the lens is just slipped back into place. And after having done that, you pull the loops out on both sides, trim them on both sides, and then simply pull a little on both sides. It centers the lens. Use an incision and close it off. And that is how the procedure ends. Now can I request Dr. Mahipal to take over, please?
Thank you very much, Dr. Keki, for giving me this opportunity. I'll be talking about the use of femtocataract for subluxated cataracts. So the femtolaser, according to us, is something that we prefer in certain situations. And one of those situations is also a subluxated cataract, which normally is a challenge. So, are you okay? So basically, when you're looking at a femtolaser, the aim of any subluxated cataract is preferably to preserve the capsular bag, otherwise you'll have to go in for a scleral fixation. And if you have been able to preserve the capsular bag, it is going to minimize the risk of vitreous loss and would therefore also allow the placement of the posterior chamber intraocular lens in the bag. And this would reduce the incidence of CME, retinal detachment, glaucoma, etc. So can we make it easier by using a femtolaser? And also a second issue, and that is to use a vitreous decompensation. So what we're going to just show you is the use of a femtolaser assisted cataract surgery along with vitreous decompensation. Now, when you're looking at a femtolaser assisted cataract surgery, the basic thing is that if you have a subluxated cataract, if you are using a needle, you don't get the traction which is adequate to do a capsular excess. And often a capsular excess becomes a difficult situation for doing, basically if you don't have a good capsular excess, your surgery doesn't go well and you are not able to maintain the integrity of the bag. So when you are doing a femtolaser, you are actually working on a closed chamber. The chamber is not open, and even if there is vitreous tags which are there in the anterior chamber, the femtolaser can cut through it and it does not need any traction, counter traction for doing a capsular excess. Also, you have already pre-chopped the nucleus. So if you have pre-chopped the nucleus, the amount of disturbance that you are causing is going to be very less and not giving any additional stress on these zonules. Now, this is a case of traumatic subluxation in a case where we are using the flax. As also we will be, because it's there has been a sphincteric tear. Now the first thing is when you are doing a flax, the pupil doesn't come well because you can see that there was a huge subluxation. I'll just pause it there. So you can see that this is, sorry. So you can see here that there is a subluxation which is, so anyway, you can see that there is a subluxation which is here and there is some amount of vitreous that is coming. Now what you can see is that the posterior capsule as also the interior capsule, just watch that will be misread by the laser. So you have to bring this up and you can have this, and you can see that we have to also align the anterior capsule so that you get a good capsulotomy. So the subluxation is evident to you, and we are doing the femtolaser. Isko yaar change kar do. You are doing the femtolaser as you can see, and the femtolaser finishes pretty well. Now you can see the sphincteric atrophy also which is there, and as you look at the sphincteric atrophy which is there, this is all over you can see, and the lens is wobbly. And as the lens is wobbly, if you were to not do a femto, this would not have been possible for you to do any other surgical procedure. Now what we are doing here is that the capsulotomy is there is a pre-chopped nucleus, and we are using the hooks, and these are the capsular hooks that you have, which are being used so that you have the lens not subluxate or dislocate totally into the vitreous. So these hooks are being placed. Once these hooks are being placed, you have a pre-chopped nucleus. The capsular axis, as you can see, comes out pretty easily. And this is the hydro procedure that you are doing very gently, and we are able to rotate the whole thing. Now just to show you that it's a gentle phaco that we can do on the pre-chopped cataract, and this is much better than if you were to initiate the first crack or the first chop which is there. Now this actually, the whole nucleus therefore comes out pretty well, and you can see the huge subluxation which is there. You can see it there, and now you are putting in the capsular tension ring, and you have to just guide it into the capsular tension ring, and once you have done that, you can pull the whole thing in a manner that the ring does not cause problem in the aspiration of the cortex. And then we fill it up with a 3-piece lens, which is going to be much better than a single-piece lens, because the haptics of the 3-piece lens also help you in the entire procedure that you have. And now you are putting in triamcinolone. In this particular case, we have not this is the vitreous that is coming, which you saw right from the beginning. So despite the vitreous tags which was there, we were able to manage this particular case. Now once you have done this in this particular case, we are using an anterior approach to remove the vitreous, and I'll show you in the next case a posterior approach. And now you do what is been described as the SFT by Amar, and we just taking in the needle, we are taking it out, and once you have this in this subluxated cataract, once we tie it, you can see that this gives you a good end result which is there in this particular case. And now you can see that there is no vitreous which is there, which the vitrectomy has been done. So this was the use of femtolaser and SFT. Now let us look at what is called as vitreous decompression. So you can actually start with a vitreous decompensation, and a valve trocar is placed in the pars plana site around the area of the zonular defect. And we can do a vitrectomy with moderate cutting rate and low vacuum, which you can have, and triamcinolone will be injected. So this was a 44-year-old non-diabetic male doctor, came to us from Bihar, post-traumatic subluxation, as you can see, and there is a huge area of subluxation which is there. It's a 6 clock hour temporal subluxation, phacodonosis, and you have a nuclear sclerosis grade 3, fundus was normal. Now the plan here was to use the femtolaser with the PCIOL, with the CTR, with vitreous decompression. So let us just see as to what we are doing. Again, you will be able to watch the capsule, which you have to again bring it into the alignment in the catalyst system, and you can again see here the iris. Just watch here the iris. You can see that the iris is coming down. You can see, because the stretch of the zonules is gone, it's much more globular, and therefore we have to move this up also. And on the catalyst system, you can actually change the capsular axis to be putting wherever you want. So capsular axis is not computed on the capsular bag, because the capsular bag has been stretched. We kind of try to reduce the overall diameter, but it is still not working. So you can see the iris is getting cut. So what we do in this particular case is to move on to what is called as a customized capsular axis. So you can have the capsular axis on the scanned capsule because it is going to come towards the center, or you can customize it. And we did a smaller capsular axis, customized it to the maximum effect that we could, ran the femto laser, and once you have run the femto laser, which is there, let us see, this is the situation that we have. In this particular case, we are doing a vitreous decompensation because you can see the huge defect right from the beginning. This is the huge defect that is there. So we are just doing a vitreous decompensation and removing the vitreous. Triamcinolone has been injected. So you can see the lens getting dragged towards the proper position where it should have been. Now, despite a subluxation and the use of femtocataract, we have a capsulotomy which is intact, which again is the first thing. We are in this particular case because of the bigger subluxation, we are putting in the endocapsular ring to begin with. And again, you can see because we had a pre-chopped nucleus, we are able to break the pieces and suck them out even in the with low turbulence in the chamber. Using a softer aspiration and a lower vacuum that you can look at. So this again, we will be able to remove the entire nucleus which has been disassembled by manual irrigation aspiration that is being done. All the time we can see that if there is any upthrust, you can actually decompress it from the ports that you have. And once we have done this, we are using a 3-piece lens as we did in the last case. And this is placed on the other side against so that it pushes the dialysis which was there. And again, whatever, this is the vitreous tag which was there. And with the triamcinolone, this vitreous tags come into play. We can do the vitrectomy. The vitreous tag as it is, we just pull it out and then use a cutter from the other side. And once you have used the cutter, you can actually have a fantastic end of the procedure surgery, as you can see. And this is the procedure that is coming to the end, and this is the post-operative picture that you have. So friends, I just wanted to show you a couple of cases wherein we used a vitreous decompensation also as a first point, or we used the femtolaser in both the cases to get a great capsulotomy, to get nuclear disassembly, and to get away despite subluxation without causing any vitreous disturbance or PCR. So these are a couple of the advantages that we have with Fentro, that despite vitreous being there, despite subluxation being there, we are working on a closed chamber and we are making the entire procedure in subluxated cataracts much easier. So this we have kind of published also as a surgical technique called as limited pars plana vitrectomy for optimizing surgical outcomes in subluxated cataracts undergoing femto-assisted cataract surgery. And the advantages of a vitreous decompensation which you have throughout the procedure is that it does not keep on hydrating. Even if it hydrates, you are able to remove the herniation of the vitreous which is there. You can deepen the anterior chamber, you can create adequate working space, and the posterior vitreous pressure which is there, which often complicates the surgery, that has been reduced. This therefore allows safe phacoemulsification with appropriate capsular fixation and expansion devices, and you can implant an intraocular lens within the capsular bag. So the take-home message is that with a femto, you use enough phaco low fluid settings to prevent surge of fluid into vitreous, tamponade the area of zonular defects with OVD, and femto-assisted capsulotomy would reduce the risk of further complications, and vitreous decompensation is the second hand or the third hand that we can use, which allows safer phacoemulsification in such situations. So difficult situations often yield the best results, and this is where the advantages of these new technologies comes in. Thank you very much for your kind attention. Thank you.
Thank you very much, Dr. Maipal. That was a very interesting concept of utilizing vitreous decompensation at the same time operating. I think it's a great idea. More people should use it. It will certainly make life easy for everyone. May I now request Dr. Kumar from Mumbai, a very versatile surgeon, to talk to us on dislocated bags and IOC.
Good afternoon, everybody, and thank you, Dr. K.K. Mehta, for this opportunity. This is 4 examples of dislocated bag and bag complexes.
Let's discuss 4 interesting cases. Case number 1 is a non-dilating pupil and a subluxated 3-piece IOL. In such a scenario, rings do not play any role due to limited exposure, so hooks have to be placed. It's important to make 4 guiding marks for the hooks and then place the hooks to get adequate exposure. Now there's a trick here. If you want to refix the subluxated 3-piece IOL, you need to make sure that it is well centered. To center that, the best way would be to mark the center on the visual axis with a Rexis marker. This will help us as a guideline to center the 3-piece IOL which is subluxated in the sulcus. Now how do we make sure that this 3-piece IOL never subluxates or dislocates again? The best way would be to make an opening in the fused anterior-posterior capsule with the help of the vitrectomy probe. Once that is done, we can capture this optic into the opening, which is what is being done now. So the inferior optic margin is captured first in the opening of the fused capsule, and now the superior margin is also captured. By this technique, the lens will never ever subluxate and ensures perfect fixation. The second case is even more interesting. It's a subluxated multifocal IOL with a YAG opening. This patient insists on multifocality. Patient was allergic to phenylephrine. Under topical anesthesia, we injected intracameral mydriatics. Triamcinolone acetate guided anterior vitrectomy is done for vitreous which has come through the YAG opening. The optic of the IOL freely rotates and we are sure that there is no vitreous entrapment. The catch here is to explant the optic disc. It's very important to hold with a micro-grasping forceps, use a micro scissors, use the incision as the fulcrum and then rotate the optic out of the incision. Once that is done, we make sure that the freely floating haptic is also removed, followed by vitrectomy in the pre-existing YAG opening to make sure that there is no vitreous. A 3-piece multifocal IOL is loaded and implanted in the sulcus, but we have to make sure that this multifocal IOL does not decenter, dislocate or subluxate. The only way to do this, of course, is to do an optic capture in the YAG opening. We now have a well-centered multifocal IOL which will never decenter again. Case 3 is even more interesting, a subluxated bag complex with an endocapsular ring. Patient gives a very interesting history that when he sits he cannot see, but when he lies down he can. So we decided it is possible to refix this bag complex, created 2 Hoffman pockets on both sides. Once that is done, we decided to fixate the same point equidistant from the optic-haptic junction on both sides and do a railroad technique. The first pass is from below the endocapsular ring and the haptic, and the second pass is from above the endocapsular ring and haptic. Then both strings are brought out and tightened. Once that is done, a similar technique is employed for the opposite side. Equidistant points are selected and railroaded. The first pass will go below the optic-haptic junction and the endocapsular ring, and the second pass goes from above. One can now see how beautifully this whole bag complex easily centers on the visual axis. We can achieve good centration by refixing the same bag complex which had actually subluxated. Case 4 is even more interesting, where there is a dislocated IOL. There is no sticker from the patient. B-scan obviously showed an IOL, but the design is unknown. What are our options? Explant the IOL, glue a new IOL, or do a posterior iris fixation. We started doing vitrectomy, and to our luck and surprise, the lens started floating up. With a micro-grasping forceps, we make sure that we grasp the lens and don't let it fall back and get it back in the anterior chamber. Interesting to note here is that these are non-foldable 6.5mm optic IOLs with dialing holes. Notice the orientation of the haptic. The plan was to glue this IOL, but in this orientation it cannot be glued. The only way out is to flip the IOL in the anterior chamber to get the orientation and angulation of the haptic correct. These lenses have a 10-degree forward angulation, so it is important to orient them in the right plane. One can see that through two 0.75mm incisions, we have now flipped the IOL in the anterior chamber, got the orientation correct. We have already made two scleral flaps on two sides so that we can externalize these haptics. This is a non-foldable 3-piece IOL with stiff haptics. So one has to be very careful in externalizing these rigid haptics because they can break when we are trying to externalize them. After externalizing the rigid haptics from the scleral tunnel, the next step, of course, is to tuck this IOL and glue it. We tuck the IOL under the scleral flap with a 26-gauge needle, and finally, we glue the original dislocated IOL in position. So through two 0.75mm side ports, the original IOL could be refitted and well centered. In conclusion, whether it is a subluxated IOL or subluxated multifocal IOL or a subluxated bag complex with ECR or a dislocated IOL, we should be ready to refix it, replace it, resupport it, or flip it and refix it. Principles to follow are: in case of a non-dilating pupil, it is best to use hooks for adequate exposure, mark as per the corneal reflex to ensure adequate centration for fixation, and capture the optic to ensure permanent fixation so that it never decenters. For a subluxated multifocal IOL, principles to follow are: use of intracameral mydriatic agents.
So you've seen all the videos, I'm not going to repeat this, but in conclusion, there are various methods of fixing, refixing, or replacing the IOLs. Thank you for your attention.
Thank you very much, Dr. Kumar. That was really very interesting and exciting. May I now have Dr. Sri Ganesh from the Netradhama? Yeah, please.
Had there not been a CTR case in that case, would you still done that lasso technique which you
No.
did, or
You will have to do a Yamane, or you have to do a glued, because it's a single piece IOL, so it won't stay there.
nowadays the older we have been using this technique now for almost 5 years now. The older technique of the cupid fixation is now revisited. You can directly pass it at the optic haptic junction.
Yes.
It easily passes through that and can be refixed, especially for the toric lenses that can be refixed back to the place.
Some doctors even suture it to the iris. That's the other way of doing it.
That's not the part.
Yeah.
Iritis and all
Some
those
doctors
parts
do
you
that.
can have.
Yeah, that's right. Thank you.
Sri Ganesh, please.
Good afternoon, dear friends, and I would like to thank Dr. Keki for inviting me to this very nice IC. So I'll be talking on modified 4-flange technique. So optical rehabilitation in patients with aphakia provides a very unique surgical challenge. There are different choices of lenses in aphakia without capsular bag support. You can use an anterochamber lens, iris fixated lens, or a scleral fixated IOL. Each of these has its own merits and demerits. If you look at AC IOLs, there's potential damage to the corneal endothelium and angle structures. The iris fixated lenses, there's pigment release, inflammation, and it can get enclaved. Scleral fixated IOLs have the advantage of a more physiological positioning near the nodal point of the eye, greater distance from the cornea. There are different techniques of scleral fixation. You have the sutured scleral fixated IOLs, which are the oldest technique, but you can have complications with these also, like suture erosion, breakage, especially if you're using 9O or 10O proline. After some years, it can erode and break, and you can have a decentered IOL again. Glued IOL, which was first introduced by Dr. Amar Agarwal, they published a paper in the GRS, JCRS. Again, you can have issues of scleral flap issues because you have to make a scleral flap, haptic extrusion, haptic breakage, till decentration, etc. M&A technique again has become quite popular, but it is technically challenging, and you can get decentration, tilt, optic capture of the IOL in the pupil. So Canabrava introduced the 4-flange technique, which has no flaps, no knots, no glue, and it's quite easy to do. So the material needed is just calipers, 27 gauge needle, 6O proline, 2 strips which is 5 centimeters long, PMMA IOL with eyelets, and thermal cautery. This was his original technique, where he used a railroading technique to pass the proline. I kind of created a modification, and I'll show you the modification. So first you actually cut 2 strips of 6O proline. I use 6O proline, and pre-thread it into a 27 gauge needle. Okay, your assistant can do this also before you start. Then 1.7 millimeters from the limbus, you pass the needle and then push on the suture so that it comes out in front. Then you go through the main incision. With a microforceps, you pull out the suture. The same thing is done on the opposite side. And then you can pass this from above, below, in the eyelet of the PMMA lens, flange it, and see the flange is secure. Place it, and then flange the other eyelet also. Then you can flange the external proline tightly. And this is a modified technique. A few interesting cases. This is a case of aniridia, aphakia, where a graft was done, road traffic accident, so the whole lens with the iris came out, cornea was badly traumatized, patient had a retinal detachment. Detachment surgery was done, and then the graft was put, but there was graft failure. Here we are using an aniridia IOL, so I'm using the same 4-flange technique, preloaded proline, and that's the aniridia lens which has the eyelets. So I pass the proline through the eyelets, flange it. I just opened a few sutures in the graft so that I have enough space. This is a very large lens, 8 millimeters, so you need to have a large opening. Flange the other side, and then you can see that I've done I'm just checking if there's some vitreous strands were there, so I did a little bit of antravitrectomy. Then I'm removing the sutures, and you need enough space to put in this very large lens. And once the lens is in, pull on the proline sutures, and then you can see that the lens centers very well. The advantage with this technique is you don't get any tilt or decentration or pupil capture. Then you flange and then bury the flanges, and then you have to exchange the graft. So the graft is again removed and then exchanged and sutured. So that's the new graft which is put in, and then sutures are put in. This patient did well. This is the day 1 post-op. You can see the aniridia lens in place with the new graft. This is another interesting case of a Marfan syndrome, 14-year-old girl, but you can see that she had almost 2.5 diopters of astigmatism, so it needed a toric lens. So I used my special lens. So I'll show you the technique. I'm using the Callisto here. I put in a trocar cannula for infusion. You can see the weak zonules there, typical Marfan's. I go in and do a capsulorhexis. Again, can do a small capsulorhexis, and I like to evacuate the whole lens. This is a hydro. I put a capsular hook to stabilize the bag, and then just with IA, it's a soft lens, I'm able to remove it. And then I remove the entire bag. There's no point in fixing this bag because it's a progressive condition, and then you can have dislocation of the lens. So I do an antravitrectomy and plan for a scleral fixation. This is a swivel haptic lens. which I'm making with biotech, and I load that in the cartridge. Inject the lens on the iris and position it along the axis. You can see it's positioned along the axis. It's a toric lens. Then I again pass the proline, pass it to the eyelet of the swivel haptic, and then flange it, and then pull on it. You have to see that the swivel haptics are exactly 90 degrees away from the toric marks there and the axis. So once the other eyelet is flanged, then you pull on it, and then you can use a thermal cautery to cauterize it, and then you can see you have a nice toric lens which is scleral fixated, a foldable IOL, and you can see that it's on axis, and this patient did very well, 6/9 uncorrected vision. We remove the trocar, and that's the end of the procedure. Thank you very much for your attention. So this is just our study, but this is the UBM post-op. You can see that the lens is placed very well. So I'll just stop now. If there are any questions?
Any questions?
That's a proprietary material. Initially we used PMMA, but PMMA sometimes can break. So that's a proprietary material, there's a patent, and then we are hoping that we'll be able to commercially produce it.
And do you take care of some torque, anti-torque in these cases, or do you pass both the side from above down, or take care for passing suture on one side from above down and other side from down above?
No, always above down.
Always
Otherwise the lens will tilt.
Okay.
Thank you.
Thank you very much, Dr. Sri Ganesh. Let's hope your lens comes out soon so we can all have a chance to use it. And now may I request Dr. Amar Agarwal, the man who has really revolutionized ophthalmology and brought it to the world stage, to give his presentation.
Thank you, Keki and Cyrus. First of all, whenever I see Keki, I only have admiration for him, so focused, so hardworking at this age in life. It's abnormal. So this was a patient who came from one of Kakinadas, and you can notice the young girl, she had a traumatic injury. There was a huge scar there, as you can see. The lens they had implanted has subluxed also. The patient also has aberropia. So another thing which you all need to learn in this game is to check the aberrations of the patient. You see, you have the pentacam, wait for 6 images. When you have the 6 images, look on this side, you can see astigmatism on one side, and look at this, the HOA, this is the aberropia which you have. It's 10.8. Please get into the system every time to see your cases. A normal is 0.3. So when I have 10.8, you can imagine how high it is compared to 0.3. Now, once I know this patient has got aberropia, I'm measuring the white to white, horizontal is 12, vertical is 11, so I can see it's a large eye. I'm making my scleral flaps. Once I have made my scleral flaps, the game plan is obviously to do the glued IOL. There you can see both flaps are made. I've got fluid inside the eye. Please play with fluid. Now move to the next phase. After you have done some vitrectomy, what you need to do is catch this haptic and bring it out. You can see I'm making a sclerotomy there. Now I'm going to catch that haptic and externalize it. So using 2 forceps, this is the handshake technique. I don't need to explant that IOL. The same IOL I'm going to refixate. And as you can see in Keki's course is what? On subluxed IOLs. So here you can see I'm making my second sclerotomy on the other side, and now I have a dangling IOL. Catch it anywhere, does not matter where you catch it. Transfer haptics from one hand to the other, catch the tip of the haptic and pull out. Once you have done that, both haptics are out. Now check how much haptic has been externalized. Look at the amount of haptic externalized, it's quite a bit. So what you do now is create your tunnel and tuck the haptics inside. So the tunnel is created by the 26 gauge needle. Entry of sclerotomy was with a 22 gauge needle. Why am I not doing Yamane? To be honest, is a great technique, or Canabrava's technique, because there will be a tilt in those cases. In glued IOL, I can tuck, untuck till I see no tilt. Now let's move to the next portion, which is the toughest portion, is can I make a pinhole pupilloplasty in this case, which has got such bad traumatic iris. Now you see the problem here is I'm trying to avoid a penetrating keratoplasty. There are 6 crore blind, ladies and gentlemen, in the world waiting for donor corneas. There is no way in the world you get 6 crore donor corneas every year. That number is a rough number. Nobody has the exact number. It is only going to increase. So can we avoid keratoplasty in many cases with better results, less headaches, no complications compared to keratoplasties problems, and use the corneas where you really need them? So here you can see I'm starting to do this technique, which is the single pass 4th row pupilloplasty. Those who have not done it, please, I advise you to start doing it the moment you get back to the OR on Monday morning, and you will see life will change for you. Here you can see I've done one area there. Now I'm trying to do it on the other side. The problem here in these cases are, it's so bad, if you notice, there's a dialysis forming on the other side also. I know the problem there from the moment we started the case, but I'm still trying to do my best as much as I can. Now, I have done this much. Can I do some more to make it more of a pinhole pupil? So now you can see I'm doing some more single pass 4th row pupilloplasty. The advantage of the 4th row is you can keep on doing as many as you want. Here you can see now, there I brought this loop out. This is the single pass. Remember the number 4, put it 4 times, and that completes that pupil. Now remember at the end, I have got fluid always going inside the eye. Remember that, as you can see, either through a pars plana trocar or through a trocar AC maintainer. Now take your vitrectomy probe. Remember one thing, all your phaco machines have got vitrectomy probes. Please remember, I'm using a Constellation which is a posterior vitrectomy, but you don't need that. All your phaco machines have got good enough vitrectomy probes, so use that to check whether I can center my pupil properly. I've now also started moving to decentered pinhole pupilloplasty in central corneal scars, but that's another story we'll talk on tomorrow in my phaco nightmare course. But here in this case, you can see I'm trying to just miss the scar. I know the area through the scar will not come out well, but the portion away from the scar, the light will go through that area. Once I made this, now I move on to my, this is called the Kalinikov gauge. It's made from Russia. It's Yuri Kalinikov. Now you can get it from Epsilon also. It's got 1 and 1.5 millimeters. It's a lovely gauge which he has brought out, Yuri Kalinikov and Ding from Vietnam. And you can see I've got approximately about 1 to 1.5 millimeter pupil there. Actually, it's a bit smaller pupil because I'm not concerning the pupil which is over the corneal scar area. Apply the glue, seal it down. Immediately the patient improved to 6/18. One was extremely happy. So I thought I'll close it here, though I have more cases, but I think it's more important as it's just crossing the time limit. So here I tried to show you a subluxed IOL with a corneal scar, trying to make you understand how you can do a glued IOL followed by the pinhole pupilloplasty. If you have any questions, please feel free to ask me.
Absolutely fantastic. Yeah, one question. Dr. Haldipurkar, you can.
Thanks for this technique.
Suhas has not spoken, huh? Hey, Suhas, I'm so sorry. I thought you have spoken. I apologize. You're not spoken also? Oh, I'm so sorry. I apologize. Luckily, I stopped it. I thought that I was the last speaker.
No problem.
Suhas, I apologize. Sorry, come again.
Standard 20 minutes. Don't bother.
Sorry, come again.
I just want to make a point. Thanks for this technique, and we have been using it frequently the day you know, advice for the 4th rows pinpoint pupilloplasties. Only I just want to add one thing, that as you were using the Constellation, the cautery of we can use the cautery of the Constellation also in case if it bleeds as a single case cautery.
Correct.
Even in the angle at times if it bleeds.
Correct.
So just wanted to make a point.
Absolutely correct.
In the
Even you can
anterior
distort the pupil correctly wherever you want by that cautery.
Yeah.
We published this in, I think, the Cornea Journal. It has been published also by us. But it's a very good point which you brought up.
Yeah. In the anterior chamber, this cautery works
Excellent.
very well.
Excellent point.
Thank you.
Thank you very much. Suhas, sorry. I didn't know this, seriously.
and you always amaze us. Good afternoon, and thank you so much, sir, for this invitation, which I always look forward to. And my talk, of course, is partly and mostly covered, but mine is post-traumatic lens back complex dislocation, and I would like to share some of my cases. Basically, when you have a lens in the back, your options are three. Whether you, if you can, you would like to reposition the bag IOL complex, or fixate the IOL after removing the bag in case the bag is all fibrous, or these days with the dead bag syndrome where the bag is totally torn, but the lens is still good, you can always fix that lens. Or finally, if the lens is not viable, you can always do IOL exchange. But there are some pearls one has to remember before you do this. Never manipulate the bag before clearing the vitreous, because that is the most important thing. Vitreous is what that's going to give you problems in the posterior part. And never pull on the IOL haptic, because it'll pull on the zonules, and it can further worsen it. Never attempt to save an unsalvaged bag. When you decide to do and halfway through you realize that there's no point in salvaging that bag, just give it up and either use a lens or get the lens out. And if you have to convert, meaning getting the lens out, do not delay it, done it fast. And be watchful about incorrect placement. Like very often we want to fix the bag, and if it's fixed inaccurately, it can cause some amount of tilt. Now this is a patient whom I had operated for a trauma as a child several years back, and then he was playing cricket and the ball hit him on his eye, and then it broke again. That time I had put a Sionis ring, with a suture, and with that trauma that suture broke off, and then that patient wanted rehabilitation. At that time I had an option, because that ring and the bag and the lens were so firmly stuck. Either I use the same ring or do something. So luckily in that Sionis ring, that central eyelet, I could use the suture, 9-0 this time, through that eyelet to bring out the suture and fix it back in the position where it was originally. And once that is done, because he had traumatic mydriasis, I also had to do pupilloplasty to bring the pupil down, because pupilloplasty is one technique which I always believe, thanks to Amar, every one of us has to practice it all the time, because the indications are only getting more and more for this beautiful technique. And finally, you have that circular, small pupil, and the patient does really well. Now this patient, I had operated 7 years before. He was holding a child, and the child just hit him, and the bag with the haptic just dislocated into the anterior chamber. Because rest of the bag and the zonules were good, I had the option to use the bag, although it's a single piece lens. If your bag is healthy, you can always use it. But for that, you have to release those adhesions between the bag and the optic. After I use 26 number to clear the space, I inject viscoelastic so that there's some space there. Once that is done, you use hooks to stabilize this bag, because if you have to use any segment before that, you have to get your suture from outside in. Here I've created a scleral flap, and with the use of 26 number needle by railroading, your 9-0 is brought out, and through that 9-0, any of the segment of your choice. In this case, I'm using a segment called anchor, Asia's anchor. It's like a paper clip which can be clipped into the rexis margin. And once this suture is taken, the suture is taken out, and the tricky part is to get this anchor inserted into the rexis margin, and you can do it with the forceps, Now these are the forceps we normally use for BHEX ring. BHEX rings, when you apply, ask for, they supply you this particular forceps, and that forceps really works good to hold that ASIA anchor. Now that ASIA anchor has got 3 arms, one central long arm which goes above the rhexis, and the short arms go under the rhexis, and you can firmly fix the bag after the haptic which is in the AC that is pushed back, and that suture comes under the scleral flap. Then you can use your glue to seal it, and with that, patient really does well. Now this is a very interesting case. This patient came 3 years after I operated him bilaterally for trifocal panoptic, and he had this picture. I mean, I was surprised to see this, because you don't find a lens dislocating, the bag dislocating in 3 years. We know of dead bag, but this cannot happen. Dead bag takes a long time. So I decided to operate him, and because it was a multifocal, I had little choice but to fix the same bag, but the entire bag was dislocated. So I chose my preferred CTS, which is an anchor, but I had to fix it on either side. So if you, it's difficult when your bag is all wobbling. You have to have these hooks to fix the bag before these anchors are placed in wherever you need to. And then, of course, there was a bit of vitreous disturbance that had to be taken care. And finally, after both the anchors were placed on both the sides. So these are 2 anchors. And what I want to say is the most interesting part. And finally, his lens was very well placed and centered. So on the 15th day, that eye was having 6/9 and 6 unaided, and he was also happy. More happy was me. But what happened was, 3 months later, he came back with a dislocation. Then I was really surprised, and I went into detailed history. And then his relative said, this man is a giant, squeeze. I mean, he keeps on rubbing his eye. So this was caused by constant rubbing of his eye. And so when you put an implant, or when patients come with such slight subluxation, you have to elicit this history of rubbing, because rubbing is one of the micro trauma constantly and chronically caused by your own cell, which leads to all this. Thank you so much.
Thank you very much, Suhas. That was a beautiful talk. Our last speaker is Professor Dr. Cyrus Mehta. He's going to quickly give us a talk on his topics, and you will find them extremely interesting. He's a very versatile surgeon with a large
Hi everyone.
volume surgery.
This is the last talk today of the course, and let's see how it goes. I'm just going to show you one video. There were lots of them, but most of it has been covered already. So this was a very interesting case. This patient has been coming to me for years together, about 15-17 years, did a cataract surgery. He was a case of, he had multiple episodes of uveitis, then he developed a cataract because of uveitis and because of the steroids. We just put in a simple hydrophilic acrylic lens, and he had some more episodes of uveitis. He was really not doing well. He was vitrectomized also once. He has vasculitis as well. And one day he comes back with the entire bag and IOL complex lying on the macula. So now what do? We have to explant everything. And how should we refix it? I didn't want to put in Prolene or suture it because it might degrade. So I did some YouTube research, which is the best research. And I chose Gore-Tex fixation with 7-0 Gore-Tex, because Gore-Tex never degrades. Gore-Tex is used to stitch heart valves, and if it degrades, then it's the end of the person. So this is the video. Let's go through it. I saw some videos on YouTube and figured out how to do it. So this is called Gore-Tex 4-point fixation. Many people have done this before. Now remember, marking the eye for IOL placement is very important, because at the end of the surgery, if you don't do it, you'll find out the IOL is decentered. During the stress of surgery, things do go wrong, so always better to be sure. Mark 2.5 millimeters. And why 2.5 and 2.5? Because you want the lens to sit 2.5 millimeters behind the limbus. And the two holes in the lens that I'm going to implant are 5 millimeters apart. This person's already been vitrectomized previously. Do a nice 4 to 5 mm scleral tunnel. Don't enter the eye. Put in 4 25 gauge trocars. And you can see there's a vitrectomized eye with fluid coming out. Have a look at the bag IOL complex lying on the macula. Naturally, it's going to go and fall there only. There's no vitreous, so it's not going to be dangling in the vitreous. Put in PFCL, levitated it, and got it in front. This was one of the original attempts, it fell back. Then we filled the vitreous cavity with PFCL. Got the IOL in the front. Take care not to bump it on the cornea. And then just get it out to the McPherson. That's the lens I had implanted maybe 10 years ago. A quick wash to remove the PFCL. Noticed also a hole there near the arcades, lasered around it. That's the PFCL gone, and this is the Gore-Tex suture. It's a 9 mm suture needle. It's basically like 7/0. So this is the lens that we use for this 4-point fixation. It's a Bausch & Lomb Acryos 4-loop lens. So you cut the Gore-Tex suture, and from one suture you can make lots of pieces like this and then just ETO it and use it again. This is very simple, just hold it with the forceps, which is your retina forceps, and get it out of the eye. So that's the front. The same thing, just thread it over the back 2 loops. Get the 2 sutures out. Here you have to be a little careful not to cross the sutures, because if you cross it, the lens will go upside down or it will twist. And you'll have to do the whole thing all over again. Just fold it in a forceps and push it into the eye. Just push it behind the iris and pull the 4 sutures. Remove tie the suture tight, but first put 2 throws so you can adjust it, and then lock it with the 3rd one. Only important thing is, after you cut it short, is that you can bury the knot by just pushing it into the opening. So this is a very nice suture, it doesn't cause any erosion, there's no irritation, and close it. So that's the only case I wanted to share. There are lots, but they are basically the repetition of the same things that we saw earlier. So that's the last talk for today. Thank you all for coming. I hope lunch was good as well. Thank you.
Thank you very much, Dr. Taras. Any questions from anybody? Please.
the regular 25 gauge retina for straight one from Epsilon.
Just a query from Dr. Suhas. Suhas, the lens which you refixated seems to be a multifocal toric lens. We need to displace again while rubbing. So what is this instrument which you use, the armor-like thing? What is this? Its make is that which you use to stretch this capsule, which is a 3 tanker. Be excellent. Okay.
Procedure that you wish to do, you can use it. It's good.
And I just suggest why a technique which I talked earlier also. The one way is to just to do the fixation by passing the straight needle from the optic haptic junction. That can easily, refixate the lens to the same axis. And one question from Dr. Just a suggestion for this thing. From you, sir. I think one of the complication reported with this Gore-Tex suture is the pigmentation, heavy pigmentation at the sites, and the lens is also hydrophilic. That's why it has gone on, because not used nowadays so commonly as it used to came with a bank AIOC technique. What's your say on that?
Oh, press on.
Well, so far the lens hasn't fallen back on the macula, so it seems to be working.
No, I understand that. But I'm just talking about the complication reported with the Gore-Tex suture. Earlier it came as bank, that AIOC Gore-Tex, then the pigmentation and the nature being the hydrophilic got it back. Your say on that?
Yeah, I partly agree with you. There are quite an instance of suture granuloma happening with this.
With Gore-Tex.
With Gore-Tex. And that knot is little bulkier. So now with the flange technique coming in, I think Gore-Tex suture has taken a back seat.
Thank you.
Thank you very much. Thank you all for coming. Even though it was lunchtime, thank you, Suhas. It's so kind of you to come. And Dr. Cyrus, very kind of you.